afternoon, everyone. Happy 2021. Welcome to the ACSM Brown Bag in Science webinar. We're thrilled to have you with us for today's presentation by Dr. Bhibha Doss. You'll hear more about Dr. Doss in just a minute, but first I want to tell you a little bit more about the brown bag and give you some housekeeping items. So this year we are using the brown bag series to highlight various ACSM regional chapters. We've been starting each brown bag with someone from the regional chapter, a leader, a student, a president, etc., to tell us about some of the activities of the chapter. Then the presentation will be from a member of the chapter. Today's presenter is a member of the Southeast Regional Chapter. So some housekeeping items. Our presentation will go for about 25 to 30 minutes, and that will be followed by question and answer. Please go ahead and type your questions into the question area on the GoToWebinar screen throughout the presentation, and we'll take as many questions as possible after Dr. Doss's talk. If you have trouble hearing or seeing the presentation, it's most likely due to your internet connection. So go ahead and log off and log back into the webinar. We are going to record the presentation, and within 7 days, we will send you the link to the recorded version. So again, thank you for joining us today. I will turn it over to Dr. Rebecca Batista. She's the past president of the ACSM Southeast Chapter, and she's going to tell us a bit about the chapter and then introduce Dr. Doss.
Great, thank you, Lynette. And it's really exciting to be here hosting today and being able to introduce Dr. Doss. My job right now is to talk to you about our Southeast ACSM Regional Chapter. I am the current past president of the chapter, and it's been a great opportunity to be engaged within the chapter at this kind of level. So our chapter actually is quite large. We represent over 10 states. We have Alabama, Florida, Georgia, Kentucky, Louisiana, Mississippi, both North and South Carolina, Tennessee, and Virginia. What is exciting about this chapter is we have a lot of engaged members, and we're very student-oriented. And some points of pride for us, I think, are the fact that, one, we do have a leadership and diversity training program that is similar to what ACSM has and just in a smaller scale within Southeast. We also have a lot of mentorship. We do have a mentorship breakfast that occurs at our annual meeting, but we do kind of pride ourselves on trying to mentor any of our members through the ranks in ACSM. We also have had some significant leaders join ACSM, and in fact, a lot of presidents have come from the Southeast chapter, and the current president-elect, Bruce Gladden, is a Southeast ACSM chapter member. We do host a fall lecture tour every year. That's pretty exciting. They usually tour around to half of the states just because we do cover quite a wide variety in terms of geography. We did it virtually this year, and who knows what next year will bring. Really depends on what's going on with the world. And we do have our annual meeting, and that's what I will kind of highlight for you today. Our annual meeting, actually our first meeting was in 1973, so this year is our 49th annual meeting. We do meet every February, that is our meeting time. This year it's going to be virtual. In the past, a lot of our meetings have had 900 to 1,000 people attend, as well as about 400 presentations. Being virtual this year, we are a little bit smaller, but we're still doing similar things that we do at our normal meeting. In our meeting, some people even call it like a mini ACSM. That's how much of the science that occurs there, the translational aspects, the basic science. So there's a lot of exciting things that occur in our meeting. So some highlights for our 49th annual meeting. One, it is virtual. It is February 18th to 19th. Right now we have over 200 poster presentations, including a student poster competition, so you can engage with some undergraduate students, masters, and doctoral students. These are the top 8 in each of those categories, and you can listen to them talk about their research project and engage and interact with them. Some of the highlights that we do have are a lot of speakers that present at our conference. This will include our ACSM president, Nicole Keith. We have a basic science lecture that will be given by John Quindry. Our keynote address is from Douglas Casa. We do have a clinical crossover lecture. So this is somebody, usually a physician, someone from the medical field that gives a talk, and trying to have that kind of crossover between the science and the clinician. And that is going to be Dermot Phelan. And then our Montoy Award lecture, this is our scholarship lecture that occurs within the Southeast chapter. That's going to be Pete Brubaker this year. From a student perspective, we also have a graduate fair. So all of our grad schools within the region, and actually some even across the United States, will be in attendance. So students will have a chance to interact with them. Our mentoring breakfast, while it's not going to be a breakfast, so to speak, they are hosting an event. It will be in the evening, and you can find that on our program on our website and look under our annual meeting program. What's unique to our chapter is we also have a sports medicine track. This is a lot of sports medicine physicians, and they actually kind of have their own separate program that also occurs during our meeting. And we encourage students and faculty, for that matter, to attend on that track and just listen to what is going on in the field of sports medicine. Our registration this year for a Southeast student member would be $10. A professional member would be $40. I did put the link of the website down here. I also put some links to our social media handles. We are very kind of engaging on our social media, so I do encourage you to attend any of that, as well as kind of check out our program, and because our program is posted on our website right now, and you can see what events are going to occur. So that's all pretty exciting. But I also have the privilege to introduce Dr. Das, and she is a very active member of our Southeast chapter, so that's also kind of exciting for us here. Dr. Das is at East Carolina University, and I'm sitting here at Appalachian State University, and we are both in the state of North Carolina. However, it's snowing outside my window, and I doubt that it's snowing in the beach in Greenville, North Carolina, where Dr. Das is. Hopefully it's not snowing there. Dr. Das is a public health and physical activity practitioner and researcher, and she has over a decade's worth of experience in the field. Prior to joining academia, she spent 4 years working with communities, including underserved and rural ones, to develop, implement, and evaluate physical activity promotion programs and policies. Part of Dr. Das's motivation to transition from practitioner to researcher was a desire to bridge the gap between practice and research. After earning degrees in public health and kinesiology from the University of Illinois, Bhibha is currently an associate professor in the Department of Kinesiology at East Carolina University, and she's a fellow within the American College of Sports Medicine. In her free time, Bhibha says she enjoys playing trivia, reading, and being physically active. We're very excited to have her in our Southeast chapter, and I'm excited to be able to open up and present and have her watch her presentation today.
Thank you so much, Becky, for that kind introduction. And actually, we do have snow today in eastern North Carolina. It is always still a novelty as a Midwesterner to see snow here in the South. My name, as Becky introduced me so kindly, is Bhibha Das, and I am here at ECU, and I'm very excited to talk to you all about my research looking at bridging the gap between research and practice. See, let me get my slides going. So my research focuses on physical activity as the behavior, and looking at how do we take physical activity and disseminate it out into the populations and into the communities where the end user can use it and the most public health impact can occur. I'm always interested in how do we increase quality of life and how do we have large public health impact. As I tell my students, I teach physical activity and aging here at ECU, and I tell my students who are often in their late teens, early 20s, that their quality of life in that age period and my quality of life in my late 30s and my parents' quality of life in their 70s is different. But at the end of the day, we do care about what our quality of life looks like. And physical activity is one of those behaviors that can allow us to have the best quality of life and live our best lives as we go through the lifespan. And so the research question that I am interested in is what modalities and characteristics of physical activity interventions are feasible, acceptable, and effective in underserved communities. And the way I answer these questions is that I use a mixed methods approach to get more robust findings. And for those of you who are not familiar with mixed methods, that's the concept of using both quantitative methodology and qualitative methodology to get a more robust set of findings. Many of us are familiar with quantitative methodology. Those are using things like the DEXA to get body composition, using validated scales like the IPAC or the perceived stress scale. Many of you, though, might not be familiar with qualitative methodology, and qualitative methodology really gets at individuals and participants' lived experiences, and data can be collected in a variety of ways. Some of the methodologies that I use include focus groups, one-on-one interviews, open-ended questions on surveys, and photo voice. And the reason I use mixed methods is a lot because of my public health background. I want to know not just the what that we're seeing, but also the why and sometimes the how behind the phenomenon. And using mixed methods allows me to answer my research questions in that robust way. Give me 1 second, I'm having some technical difficulties. All right. The other thing I look at is community-based participatory research. And this goes along the idea that community members and researchers work together to combine knowledge and action for social change to improve the community's health and also to reduce health disparities. The reason I use this approach is that it helps build trust and capacity to improve the community's participation in research. It allows research to be more equitable. And finally, it allows community members the agency and ownership in the work that's being done in their communities. And this is especially important in these underserved communities that often feel they're ignored or not valued when we're doing health behavior research. And also this type of research coincides, goes nicely with the motto at ECU. Our motto here is to serve. And so I use my research here to serve the community that I have the fortune to work and live in. So why underserved populations? So you can see here differences in far as demographics goes for people who are meeting the physical activity and public health guidelines. And there are significant physical activity disparities, whether you live in a rural environment or an urban environment. Those of us who live in a rural environment, only 19.6% of us meet physical activity guidelines versus the 25.3% in those urban areas. When we look at men versus women, 20.1% of women meet guidelines versus 28.8% of men. And then when we look at race, only 20.8% of African Americans meet physical activity guidelines compared to nearly 27% of white Americans. And then the disparity that I think is one of the most startling is the one between college graduates and high school graduates. Individuals with a high school degree, only approximately 17% of those individuals meet physical activity guidelines, compared to nearly double that, almost 34% of individuals who are college graduates. So individually, these disparities might not seem like a big deal to an outsider looking in, but cumulatively, they can have some very detrimental impacts. And when we see these disparities in physical activity, those we know from their literature can also translate to disparities in health, such as a decrease in quality of life, an increase in chronic disease risk and chronic disease incidence, decrease in work productivity, decrease in your activities of daily living, and these also can have generational impacts as well. So it might not just impact you, but it can impact your family alongside that. So why housekeepers? As many of you as students, or if you're on the tenure track, you spend a lot of time at work during the evening hours and during the weekends. And I always tell my own graduate students that inspiration doesn't always come from reading the journals. it comes sometimes when you least expect it. And so one day I was working at Minju Coliseum, and I observed one of our housekeepers using her housekeeping cart as a walker. And that just prompted some sort of intellectual curiosity in me of, I wonder what do housekeepers think about physical activity? Do they value it? And why don't we have interventions targeted toward that group? And so we know that there is an established relationship between race, ethnicity, and one's socioeconomic status with those negative health outcomes. We also know that work sites are an ideal setting for health promotion programs because these work sites have a similar culture and similar policies. We also know that housekeepers are often comprised of minorities with a low SES status. And in the United States, nearly 926,000 individuals are working in housekeeping. But what should be noted is that university housekeepers are actually not considered in that number because they are categorized as higher education workers, which can be a little misleading when we're looking at the statistics. And when you look at university housekeepers within the literature, there's actually very limited data about this particular subsector of the workforce. But we do know that there is a established relationship between health, morale, and productivity. And so my students and I decided to pursue that a little further. And so what we found about the housekeepers at ECU is that they are predominantly African American. Nearly 98% of the housekeepers are African American. They are predominantly women. They are also of low SES status, and they are rural residents. Eastern North Carolina, for those of you who have not had the pleasure of visiting, is very rural. It is historically tobacco country, and Greenville, North Carolina is usually considered the hub of Eastern North Carolina. And if you recall back to the previous few slides, this is a perfect storm, if you will, of physical activity disparities with African American women who are low SES and rural residents. So the housekeepers at ECU, this prompted a continuum of studies, if you will. The first study I did was called the Invisible Employee Study. That was actually done my second year here at ECU, followed up with the Healthy Housekeepers Initiative. And then the next step was supposed to be the Clean Up Your Health Study, but unfortunately COVID hit, and we had some other administrative issues. So I'll talk about what we're planning to do as well. So the Invisible Employee Study, the study is in Journal of Physical Activity and Health, and the goal of this study was to explore perceptions of physical activity from the housekeeping workforce. I used the health belief model as a theoretical underpinnings of my study, and we used a mixed method study. We had focus groups, and we also asked participants to complete the ITAC and to wear a pedometer to understand some more of their physical activity behaviors. And looking at the demographics, you can see that the majority of the housekeepers in the study were middle-aged, all were female, and all were African American. And then if I can draw your attention to the education level here was what we would consider low SES. No one in this sample had graduated college. We had 2 individuals who had done some college, and then those other 2 individuals had done some type of training program, a vocational training program. And then when you look at the income again falls towards the lower SES spectrum. And you can see the physical activity steps per day. We used the NL 1000, and that was almost 7,000 steps a day. Their physical activity, according to the NL 1000, were about 53 minutes. And what was interesting about this, that they felt that they had been active based on the ITAC for 205 minutes. So definitely a great disparity between what they were actually reporting, or what we were seeing objectively, versus what they subjectively felt using the ITAC. So we had collected that data, and then I did focus groups with the participants. And the focus groups was, again, followed along the lines of a health belief model. And this health belief model used the concepts of perceived susceptibility, perceived seriousness, the benefits and barriers of being physically active, how one's self-efficacy towards being active, and the cues to action. And you can see there the questions that we asked to get to those components of the health belief model, and then the themes that we found. So some of the major themes there were that there were detrimental effects on one's health status, and not just physical effects, but mental ones as well, such as stress, anxiety, and depression. That there were tangible effects on one's finances because of their poor health condition. And this was one that really was stuck home for them because of their low income anyways. Having that additional burden of medical expenses was an additional financial burden. Other things that they thought could help them to be more physically active was actually the university's investment in employees' morale. And I'll talk about that here in the next few slides. So looking at some of the quotes that came out, they recognized that being active would definitely help with their health problems. They were very cognizant of that it would help them with their blood pressure, their diabetes. Their reasons for wanting to be active really went back to they thought they needed to be there for their families. For many of these women, they were the sole breadwinner for their families, and realizing that not being active might not allow them to work anymore was this moment of clarity for them. And then when we talked about why they didn't want to work out after or be active after work, they were just tired. For many people, this was one of 2 or 3 jobs that they held, along with caring for family members and for children. And so adding exercise or activity on top of that seemed very daunting for them. And then finally, for them, there was a huge financial barrier. We do have a beautiful rec facility on campus, on main campus, but it can be pricey, especially for people who are on that lower spectrum of the income bracket. And you can see here that people wanted to have the gym, but they didn't want to have all that money to spend on the gym. That wasn't something that was financially feasible for them. One of the things that really stuck out to me, and stuck out to actually one of my students, was this quote that came from an employee about morale. And I want to take some time to read that because I think it's incredibly important, especially during the time of COVID and with our university housekeepers being frontline workers during this time. I clean the bathrooms 364 days a year. It's the 365th day that I forget to clean that someone pays attention to me. I don't get praise. I just get criticized. How would you feel if you only were paid attention to when you messed up? And I think that's such a telling thing about morale and productivity and how you feel invested in the university community and how that would want you to do other things like take care of your health by being active. So that study then led to the second study, the Healthy Housekeepers Initiative. And this was to look at social support on work-related outcomes along with physical and psychological health among our housekeepers here at ECU. It also served as a needs assessment survey, and again, we did mixed methodology. And you can see here, let me go back to that slide. You can see here the age was very similar. It was middle-aged again. We did have some males in this study, but again, skewing more towards females, skewing more towards African American. And then when we look at the education level, there was a little bit more, the spectrum was a little bit greater variability as far as educational and income level went. And you can see the physical activity steps there were very similar to what we found in our prior study. So we looked at job satisfaction and support using some validated questionnaires, and we found this questionnaire that measured job satisfaction was on a Likert scale from 1 to 7, with 1 saying strongly agree and 1 being strongly disagree, and 7 being strongly agree. So job satisfaction here averaged about 4.43. So more towards the somewhat agree, with stress levels being occasionally high for nearly 75% of the sample. When we look at support, we asked our housekeepers, how supported did you feel at your job? And we looked at support between colleagues, by your supervisors, supervisors. We saw the highest perceived support was intangible support. And this again was on a Likert scale, with 1 being definitely false and 4 being definitely true. And you can see that the data skew towards more being definitely true, especially in the tangible support. And tangible support was the idea of someone physically providing you something. And these examples that came out in the focus groups and interviews that we did later were a colleague pitching in so that you didn't have to stay overtime and you finished cleaning your building on time, sharing equipment and supplies, running out and grabbing dinner for not just themselves, but also for the colleague as well. And so that support was definitely there for colleague to colleague. But what we found in our focus groups that support was not there as far as their supervisors went. And so, this came out where they didn't have the support and the trust of their supervisors. They didn't feel like their supervisors valued them, and they didn't feel like they could trust their own supervisors. And you can see here that people were afraid of talking out in case they were retaliated against. There was that lack of respect also from other members of the university committee. So I've been over there working for about 13 or 14 years, and not once did they invite me to their Christmas party, and they're on speaking terms with everyone else. And then the impact of the job on their health overall. To keep us healthy, you need more help so you won't be all stressed and tired, because when you're tired, you can injure yourself because you're rushing through things. And so we took that data, we listened to what they wanted in a health education program, and we created our next intervention, the Clean Up Your Health intervention. And this is looking at a 12-week social media-based intervention on their physical and mental health. We used components of the diabetes prevention program, and we're going to use mixed methods as well. We're interested in the flexibility of using social media and the idea of using social support, so having partners signing up with one of your friends in the housekeeping group and having students in kinesiology and nutrition work as health coaches for them. And one of the reasons we did this via social media is that many of our participants reported having no time for in-person classes because of the conflicting demands. Second or third jobs, child care, parental care, homeschooling their children now because of COVID. And then the other thing that they wanted, other than just physical activity and nutrition information that's critical to the DPP, is they wanted stress relief options as well. So we had added some stress options to complement the DPP as well. So I have a student working on that currently. So what's the take-home message? As a public health person, I'm always interested in the so what. We learned this, how do we take this and put it into place with our programmatic and policy implications? So programming, the things we found from our housekeepers is that they want free or low-cost programming. Asking a housekeeper to pay for something just stretches them out financially. It's an extra financial burden that they just can't take on. It needs to be accessible for them, so things that they can do on their own time with the options of being flexible. It needs to be inclusive, so including people on all shifts. One of the things we heard is a lot of times there are opportunities for people who work the traditional first shift, the 6 to 2:30 or the 8 to 4:30, and that people who work second shift or third shift were often ignored when it came to programming efforts. It wanted to be holistic. Of course, people are interested in physical activity and nutrition, but they also wanted a lot of things about stress management and wellness so that they can live their best lives and improve their quality of life. Meaningful incentives were important to them. They wanted things, one of the housekeepers told me, I don't need any more t-shirts. I have plenty of t-shirts. They wanted things that were meaningful. So release time to participate in these programs, and having insurance premiums or even financial incentives would help. And programs that are tailored specifically to housekeepers. One of the things that we heard in our focus groups is that a lot of people try to give a cookie cutter approach, that if this program worked with faculty and staff, then it should also work with the housekeepers. And they just have different expectations, different schedules, and quite frankly, as they said, a perceived class system within the university. And then the policies that they wanted. They asked if they could have release time, from the research has shown that employers who have release time and have flexibility for their employees to be active and engage in health education programs on work time have better engagement. Insurance reimbursement, so things like if they lower their A1C or if they keep a healthy body weight or lower their body weight, improving, getting those reimbursements. And then the environment, and having the environment so that there are things within your community, within the work site that foster physical activity, that physical activity becomes the natural choice instead of the harder choice. And then the last piece is the higher education piece, having diversity in our training programs within our departments of kinesiology. And as Becky mentioned, ACSM and Southeast ACSM have a great leadership and diversity training program. So I'm glad to see that Southeast is doing their part to help foster some more diversity in the students that we get in kinesiology. And so then I couldn't end it without talking about what the students gained. First of all, students gained course credit. So many of my students take a research opportunity to get that course credit. And then they get that safe experience. I always tell my students that people make mistakes. If you make a mistake, come to me so that we can change that mistake into a growth opportunity. The next thing is they've got an appreciation for diverse populations and lived experiences. For so many of my students who are coming from communities in Eastern North Carolina, this is the first time they're engaging and working with people who don't look or live like them. And so understanding that physical activity is for everyone is such a light bulb moment for them. They also finally have an appreciation for the passion for research. They understand how do we take that science, the theories that we've learned in class, and apply it into community settings. Having it be translational so that it's not just sitting in a journal and putting place into the communities that they come from and that they'll hopefully go back and live and work in. And as my students, I tell them, we should be doing research to improve the human condition, not just to add lines on our CV. And I think my students have really taken that to heart, and I'm very excited for all of them. And so some acknowledgments. I could not do this work without the ECU housekeepers. I'd like to send a thanks to the ECU's Office of Equity and Diversity who have funded some of my research, and of course my undergraduate and graduate students who transcribed my data, and thank you for that. And here's my contact information. I'm always happy to answer any questions. Email is the best because I don't go into my office that much anymore. And then, of course, a thank you.
Great. Thank you so much, Bhibha. That was a great presentation. And everybody who's listening, we have some time for questions. So please go ahead and type your questions into the question area on the GoToWebinar platform. And we've got a few questions here to get started with. So Bhibha, you talked a bit about that these folks are already getting some activity within their work, with their daily jobs, about 6,000, 7,000 steps, things like that. Can you tell us a little bit more about the beliefs they had related to adding more activity or adding more intense activity to their days?
Absolutely. So many of them felt that the incidental steps that they were taking, walking through the buildings, emptying trash, cleaning facilities, was enough. But what we talked to them more about was more moderate and more vigorous types of activities. And many of them were open to the idea. They just didn't know, A, how to do that type of work because they had never worked with a personal trainer before, didn't have the resources for personal training or any other of those types of activities. But they also were uncomfortable with doing this. So they were receptive about it. They just needed the support to get started so that they can maintain that behavior.
Great, thank you. So here's a question that just came in. It says, I'm really interested in this research and excited to look at it. In my job in health improvement in Scotland, we use a health behavior change approach called MAP. What health behavior change techniques and approaches do you use for your practitioners?
So I use, and I'm just biased to this because I used it for my dissertation, the trans-theoretical model and the social cognitive theory are two things that I always value from the from the trans-theoretical model, understanding where people are in their stages of change. If you're not even thinking about it, me giving you a health education program is a waste of your time and my time. But identifying where people are in their stages of change will allow me and other practitioners to identify different strategies to help you make that behavior change.
Great. Can you tell us a little bit about the response from the university and their reaction to providing work to employees?
Absolutely. So we had, when I started here at ECU in 2013, we had a fairly robust university wellness committee, and they were very active and interested in this type of work initially. And we've had, unfortunately, some leadership changes and people retiring. And when people have retired, they take with them their passion and expertise, unfortunately. And no one has taken that up recently. I am hoping that with the push that ECU has made toward our unsung heroes, as they like to call our housekeepers right now, that there will be more of an incentive moving forward to provide these opportunities for this class that is often underlooked in health promotion programming at universities.
Great. So hopefully they'll look into making some changes at the university following, your work. Let's hope. Fingers crossed. Yes.
Fingers crossed, absolutely. If we could just get even work release time, I think that would help immensely.
So Bhibha, for folks who maybe aren't as versed with the public health sort of approach, can you talk about or describe the different approach to developing an intervention via a public health approach or model versus when you're trying to change the activities of individuals?
Absolutely. I think one of the big things when you're looking at the public health approach is that we as researchers think a community, we think a community needs something. And oftentimes what we do a poor job of doing is going into the community that is actually our target for our intervention and asking them, what is it that you actually want? And doing these needs approaches you've seen through my research has allowed me and my students to go within the community of the housekeepers and ask them specifically, what are some of your barriers to being physically active and engaging in a physical activity program? What are some of the facilitators? And what do you need in a program to be successful? I could design the best program out there from a theoretical model, but if my community of housekeepers don't think that's acceptable or feasible, then I'm just not going to get them in there. So for any researcher who is looking at designing interventions, I would say go and do a needs assessment with a community that you are targeting, because you'll learn more about what works in that community than just simply, reading a paper or using a theoretical model that you're familiar and comfortable with. Great,
thank you. So we have a question. Have you considered the lived experience of the study population? Their living conditions, the environment, number of children, access to education, those sorts of things?
Absolutely. So when I use the term lived experience as far as in the qualitative methodology, the idea behind that is I want to know what what has their life been like? I want to put myself in their shoes and look at physical activity through their eyes and their lenses as a community member, in this case, a housekeeper, than my eyes and my lens as a researcher. So when I use that term lived experience, exactly it. I'm interested in, what do you do after you leave ECU? What does your life look like? How do you feel about your job here? So getting beyond just the numbers and getting, like I said, not just the what, but the why and the how of why they do things or don't do things.
Great. So there's a question about what do you see as the biggest barrier to community-based participatory research?
Trust. I think a lot of communities have distrust of academia and the government, especially these underserved communities, and rightfully so. And so building trust and being transparent and accountable when you're working in these communities is really important. Just going into these communities to write a thesis or a dissertation or a grant and then just ignoring them afterwards is a disservice, and it builds hostility and a lack of trust. And so, Miss Barbara is our housekeeper at Minji's Coliseum, which is my building at ECU, and I know Miss Barbara. I know Miss Barbara's son is a basketball coach. It's those simple things that help build trust in that community. And Miss Barbara, quite frankly, was a gatekeeper for me when I went to go recruit for my studies, because she knew me and she knew that I genuinely cared. And so I would say the biggest issue there is trust, and ingraining yourself in that community and finding a gatekeeper, and not just using that community for your own research is really critical to moving this type of research forward.
Great. And to what extent, as you're involving your students in this type of research, any sort of cultural competency training with your students?
Absolutely. I have my students go through some cultural competency trainings. They do some trainings looking at privilege and advantage. And moving forward, I'd like for them to do some more racial equity training as well. And the one thing my students have learned is to know the name of the man or the woman who cleans the building that they study in. And so if that's the one thing they've taken away from it, that they pay attention and say hello to the housekeeper, I think that's a really important lesson for them to take away.
Okay, so our next question is coming to us from Puerto Rico, and I'm going to guess it's not snowing there, so that's good for that person, yeah? So the question is, have you measured behavior modification in terms of participation in physical activity, and what are the best strategies for participating in healthy behaviors?
I have not. So our first two studies were exploratory studies. The Clean Up Your Health intervention is actually one where we will measure that, but that is a great thing to include in our measures. So thank you.
So in your research, were there barriers to care that you think contributed to the lack of healthy activity or physical education, and do you think they regularly had access to seeing a physician?
Let me answer that first, the last half of it. I think there are issues to access to care here in Eastern North Carolina, and seeing a physician in a timely manner. So I think those barriers and lack of access may influence whether a housekeeper gets proper care or not, or preventive care. And I'm sorry, Lynette, I lost you on that first half of the question.
Yeah, I think that was mainly it. To what extent does sort of a lack of access to care contribute to beliefs and activities, behaviors around being physically active and the health benefits of it?
Yes, and I think the other thing that comes out with this is that many healthcare providers are not trained in physical activity prescription. And so even though they may be quote unquote prescribing physical activity, what are they actually prescribing? So there's a gap there as well. We have physicians and healthcare providers who know it's good for us, but they don't know exactly the quality and quantity like those of us who are studying it every day do.
Great. And somebody's asked about maybe future studies, and do you have any interest or have any intention to look at supervisors and maybe provide education to supervisors so that they can also positively impact, the workplace culture around physical activity?
Absolutely. I think that's a great question and a great point of future research. There are trainings that our HR department does, but I think more meaningful trainings about health and the impact on health on not just physical health, but also job satisfaction is going to be critical. So I think adding that piece about how health impacts job satisfaction and morale will really resonate with supervisors.
Great. We have time for two more questions. So one is, have you identified other underserved populations within the higher education environment?
I have not. I've been focused on the housekeepers, just limited time and energy and resources. But yes, I have not, but I'm sure there are other subsectors that are not being studied. The one that comes up to my mind immediately are like our service and maintenance staff. So the people who move our equipment, our electricians, those are people who definitely need to be studied as well.
Okay, and our last question, if somebody's working with clients who get a lot of activity within their job, so maybe like your housekeepers, postal carriers, so what are some recommendations you would make to help those individuals get more active, or when they're working with somebody who's come to them and they're seeking a personal trainer, they know that they need, to do additional exercise or different exercise for their health. If somebody's already doing a lot of activity within their job, what can a personal trainer, for example, suggest or at least plant the seed around ways to be more active?
That's a great question. One of the things I would do if I were working with a client like that is identifying what types of activities that they're doing, and not just the types of activities, but the intensity. So you can see that in my first study, the housekeepers thought they were being really active, but when they looked at the minutes of activity, it was only about 60 minutes a week of activity. So one, identifying what they're doing. Two, identifying what they're interested in doing, and then having that discussion along those lines. And as many things as COVID, there's a lot of things that COVID has taken away from us, but one of the things COVID has given us has been the ability to do some of these virtual trainings and one-on-one coaching virtually. And so, I would encourage people who are working in these facilities, whether the YMCA or a hospital training facility, to reach out to local universities and see if there are students who are interested in getting more experience training a different population to help that population and the student get the most out of it.
Great. Thank you so much, Dr. Doss. I'm going to ask you to reverse your slide deck, just one slide, so that people can see your contact information again. And we really want to thank you and Dr. Batista for being with us today. If people have questions for Dr. Doss, you can reach out to her on the ECU website. So we encourage you to reach out to her if you have any final questions. We want to remind you not to forget about the Southeast Chapter meeting that's going to be held February 17th through the 19th. And if you would like some additional information about the Southeast Chapter, you can always find that on the ACSM.org website. So thanks again to Dr. Doss. Thank you, Dr. Batista. With that, here in the National Office, we're going to give our round of applause, and we will end the webinar now. Thanks, everybody.